It's a really great segue to using the word policy. Tell me a little bit about sort of what you imagine good, exciting policy changes might be that you could see in the years to come.
I mean, that's such an exciting question for me. So I think a couple things, I want to be able to answer the basic questions. Does our current curriculum address what could be out there in terms of equity issues, right? Or things we might already know? Are we changing our regulations so that our training programs help to close these gaps, or EMS providers get more knowledge in a certain area to help close the gaps? When we get to analyze medical outcomes for patients statewide, if we see discrepancies by race or gender or whatever information may come out of that, how will then we, with our chief medical officer, say, we need to implement protocols that if someone is feeling chest pain, they will receive an EKG, right? Regardless of gender. Just simple things that if you know the gap exists, I, maybe naively hopeful, don't believe that anything can't be solved. But if you don't know the gap exists, you can't solve it. And so I think it'll be really exciting policy conversations in our clinical care standards and our training standards, and then really inform us when new legislation ideas come right onto the floor and we're having these conversations, looking at everything with that equity lens, or knowing that these gaps exist, ensuring that we are working with the legislature to make sure, even though something might be equitable or being done in an equitable way, this could have a perverse impact. And let's talk about that and how do we work through that. So I think that's what I hope for the future of behind this work, is that it really drives these other things to happen.
Much of our conversation has sort of hovered on workforce and implicit bias that may be manifesting in some of the ways that we greet people. And I sort of want to pivot to the more systemic inequities, right? That can, by default, manifest in different health outcomes. Particularly, one of the pressing things that's coming up for me at the moment is this idea that trauma centers in the state of California are not sort of beautifully, equitably, rationally distributed around the state in a way that it might take some people longer than others to, for example, get to a stroke or, a stroke center, or getting to a specialty center that they may require, and that we may see some differences. What could we potentially do together to deal with some of the more systemic differences? How resources are actually just divided around the state of California. What are your thoughts about that?
No, I think it's an excellent question. And I think infrastructure, right? This is such a key piece of everything right now that is being talked about in California, right? How do we, it's not, just trauma or STEMI or strokes, specialty care programs or centers. It's, it goes even more. Where are the behavioral health facilities? Where are the sobering centers? How are the urgent care clinics, distributed? And how do we get care to the patient, the right level of care at the right time in the right way? And so I think this is a part of the work. I think it's one of the pieces of equity that we absolutely want to analyze and look like. And I think defining with the statewide community, what is an acceptable transport time? What is an acceptable rate time? And does it vary by not only race and ethnicity, but does it vary by gender? Does it vary by age? Does it vary by disability? Does it vary by so many other factors? I think, or just so many factors. I think looking at all that is going to be a part of this statewide work. And I think it will go beyond just the trauma centers or STEMI stroke. I think it's, where is the healthcare infrastructure in California, and how does the EMS system, how accessible is it to the patients? So I think, just to go a little deeper down this rabbit hole, accessibility of the California EMS system, I think this is where partnership is so important. It's really kind of two prongs of this fork. Not only is it the EMS system, the providers, the ambulances, having access to the healthcare continuum. Do they have the right resources in their community? Do they have enough hospitals? Do they have enough infrastructure? But it's also then, do the patients have access to the ambulances? Are there excessive wait times? Are the patients being seen and heard for what they're experiencing in that moment? Is there implicit bias? Is there differences in medical treatment based on race, gender, ethnicity, whatever, disability, whatever that may be? And so I think this is all part of that larger conversation that we really want to look at in a comprehensive way. And it will be curious to me as we go to write this definition, how this forms, because equity in EMS is so big, right? It's so complex, and there's so many pieces that need to be accounted for a comprehensive assessment, really.